So hi, everyone, and thanks for joining the CDTRP's Level Up webinar series. My name is Elaine Yong. I am a CDTRP PFD partner. That's a lot of initials. But basically, I'm a patient partner with the CDTRP. I'm also the PFD co-lead for Theme 4. I will be facilitating today's webinar. So I'd like to first of all start by saying that the University of Alberta hosts the CDTRP, and we respectfully acknowledge that we are located on Treaty 6 territory, and we respect the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. And I would like to personally acknowledge that I'm speaking to you today from the traditional, ancestral, and unceded territory of the Coast Salish peoples, the Musqueam, the Squamish, and the Tsleil-Waututh nations, otherwise known as Vancouver. I'm really privileged to be a settler on these beautiful lands, and I feel so much gratitude for the First Peoples who have taken such great care of the forests, the mountains, the oceans, and all the water that surrounds us. And, we started hiking as a family at the beginning of the pandemic because we couldn't do anything else. Our two girls dragging them along. The youngest was, I think, not quite 4 yet. And, every time we go out there, I really hope that I and my children can learn from the Indigenous ways and also be stewards of this incredible land that we honestly have just felt so fortunate that we are settlers here. So I also encourage you today to share your land acknowledgement of where you are coming from in the chat box. It's always so great to see where everyone is coming from and the acknowledgement of the lands. So today, CDTRP is excited to welcome Shelby Gielen, Jordy Hermiston, Jordan Wadden, and Alice Virani, who are presenting on this topic, exploring the ethical considerations of direct contact in pediatric organ transplantation, a qualitative study. So I would just like to first of all say that this is a subject matter that is very near and dear to my heart personally. I'm the mother of Addison, who is a heart transplant recipient. She is celebrating her 11th year post-transplant. She had her transplant when she was an infant, just 3 weeks old. So full disclosure, I actually participated in the study as one of the participants. Also, I feel like this is something that means a lot to me because we have actually met our donor family. And, I think obviously everyone's experience is so different, but it's been something that has enriched our lives so much. And it's really changed the way that I feel about organ donation and transplant, more so than I think you'd ever, you can talk about what you think it might be like to meet your donor family or for a donor family to meet a recipient. But I think until you have that experience yourself and everyone's different stories coming together, it's been so powerful. It's really made me think about so many different things. And it's not anything that I would ever, I wish that everyone could have the same experience. And I think for me, I think the biggest thing is that it really changed the way I felt about the donation side. I always thought of it, and I think a lot of recipients feel the same way, that you're kind of like in this oh, we're taking something from the donors and the donor families. It's like, oh, we're taking and we're the ones who are getting this gift, and they're the ones that are losing out. But my donor mom, Felicia, really showed me that for her it has been an incredible gift to be able to give. And that was kind of like a real light for me, because I felt all this guilt, like I think a lot of recipients do. But meeting her and hearing her side of it and just seeing the joy that it brought her, it didn't take away the sadness. It doesn't take away, those feelings of why. Well, actually, she doesn't question why, because she feels like her daughter was born to give, and her daughter Audrey was 6 days old when she became an organ donor. So I think that's really shape the way that I feel about organ donation and transplant and the message that I share with people, because I've realized it is a gift on both sides, and to be able to see that firsthand has been so powerful. So anyhow, that's my very long introduction, but a few housekeeping notes before we actually get started. Today's webinar and discussion are being recorded and will be posted on the CDTRP website and the YouTube channel. During the presentation, we kindly request that you turn your camera off and your mics as well. Once the presentation is complete, we ask you to turn on your cameras. And if you have a question or comment, you can ask our presenters directly, or you can also send me a private message if you want to keep your questions anonymous. So Now I'd like to introduce the fabulous team who's part of this study. Shelby is a two-time liver recipient, having received her first transplant at 14, her second one at 27. And she just shared with us this morning that the road to her third liver transplant is now fully on its way. Shelby has become a very strong advocate for transplant recipients and their families. Throughout her youth and adult life, Shelby has remained active in the transplant community as a mentor, a volunteer, and an athlete in the Canadian Transplant Games. As a patient partner in research, Shelby is passionate about using her lived experience to infuse the patient perspective into the research process, leading to improved outcomes and practical solutions. Thank you, Shelby. Okay, we've got two Jordy, so separate, but Jordy Hermiston, so you can call Jordy, Jordy is the program facilitator of donor family services at BC Transplant, where he's dedicated to supporting the families of organ donors following the death of their loved one. Jordy is a registered social worker, and prior to working with donor families in the community, he practiced in several intensive care units and emergency departments in the Vancouver area. He has a master's in social work from UBC. The other Jordan Wadden, is a full-time bioethicist and ethics department lead at Ontario Shore Centre for Mental Health Sciences. He also facilitates a regional ethics hub, which consists of additional hospitals, rural health centers, children's centers, and community mental health organizations in the Central East region of Ontario. His approach prioritizes including patient and family voices and emphasizes the clinical decision-making benefits of being comfortably uncomfortable. I love that. As a researcher and advocate, Jordan's work focuses on equitable access to healthcare, disability advocacy, and the implementation of artificial intelligence and machine learning in hospitals. He's currently wrapping up a PhD at UBC, where he focused on the patient's patient's ability to consent and the clinician's obligations when employing powerful artificial intelligence in diagnostics. He has a master's in philosophy from Toronto Metropolitan University, formerly Ryerson, also my alma mater, not in science, of course, but in journalism. Alice Virani is the Executive Director, Clinical Ethics and Spiritual Care Services at BC's Provincial Health Services Authority and a Clinical Assistant Professor in the Department of Medical Genetics at UBC. Alice is a passionate advocate for equity-based healthcare decisions and provision with a strong emphasis on cultural safety, trauma-informed practice, and humility. In addition to her work at PHSA, Alice is passionate about the role of ethics at a national level and proudly serves on the Interagency Advisory Panel on Research Ethics, CIHR's Ethics Committee, and the Public Health Ethics Consultative Group for the Public Health Agency of Canada. So a really amazing group of people who've been involved in this really important work. Thank you so much to all of you for joining us today. So let's get things going.
So thank you so much, Elaine, for that wonderful introduction. Like you said, it's a very immense, it's a very big, sensitive, incredible topic that we studied. And, you know, just before we delve into that, I just want to quickly acknowledge that Alice, Jordan Hermiston, myself, we too are situated on the traditional, ancestral, and unceded territory of the Squamish, the Tsleil-Waututh, and the Musqueam people. And Jordan, Joseph Wadden, he's actually joining from the lands of the Mississaugas of the Scugog Island First Nation under the Williams Treaties. The Mississaugas are a branch of the Greater Anishinaabe Nation, which includes the Algonquin, Ojibwe, Ottawa, and Potawatomi. So we just want to acknowledge that, you know, all of us and some of our many study participants as well may reside on these lands or some other lands. So we also just wanted to acknowledge the funding. We could not have accomplished this project at all without the help of the, without the help of the Transplant Research Foundation of BC. This project was actually funded by a 2021 TRF BC venture grant. So that's what allowed us to move forward. So with that, I'm going to hand it over to Jordy, who's going to kind of give you the background. Jordan or Jordy, one of you two.
Me first. So you can just advance the slide there. Yeah, I'm just going to talk about, as kind of Elaine introduced, I work at BC Transplant and doing donor family services. So I did a lot of work, and we did a lot of work to launch this direct contact policy and process in the adult population. And so this is an established policy and process that is predating its availability for in the pediatric program. So just an overview of how direct contact for adults works. It's kind of an extension of the anonymous correspondence program between donor families and transplant recipients, which I'm sure lots of you are aware is a really well-established program across a lot of organ donation organizations across many provinces and countries. Direct contact for adults was established in BC in November 2019, and it was established with three criteria for qualifying for this, namely that direct contact, well, it's, it's defined, I guess, as the interaction between a donor family and transplant recipients that is not anonymous. It can be independent of or facilitated by a member of the healthcare team, and it can include the exchange of names, personal email addresses, mailing addresses, telephone numbers, or in-person meetings. And this is kind of established based on the needs and expectations and concerns of all people involved. And the most important thing, I think, for the adult side, but as well as the pediatric side, is that direct contact was created, and this program was created in response to self-advocacy from donor families and transplant recipients. We've heard from many in this community that the kind of traditional, more paternalistic structures of healthcare organizations, healthcare systems in limiting patient and family control over their own identity and their own information was no longer, is no longer acceptable to a lot of folks in this population. So as I said before, there's three criteria for direct contact in the adult program. Namely, the donor family and recipient must have exchanged anonymous correspondence at least once. A minimum of 12 months have had to have passed from the date of transplant. And BC Transplant has to have received initial independent requests for direct contact from both the donor family and the recipient. This means that a donor family, for example, couldn't write in a letter, an anonymous letter to a transplant recipient, "I would like to meet you" at some point. They need to express that interest in direct contact independently. This was important because in our focus groups, when we were establishing this program, we heard from many donor families and transplant recipients that really wanted the opportunity for direct contact, but for many, anonymity was equally as important to them. And so we wanted to eliminate any possibility of coercion or a recipient or donor family member maybe going beyond their comfort to out of some sense of obligation to the other person. So when there's a match, a social worker, myself from BC Transplant, supports the donor family and the transplant recipient through a consent process where we discuss kind of expectations, hopes, fears, boundaries, strengths, and their support systems, and co-create a direct contact plan that feels comfortable and meets the needs of all involved, whether that is starting small with just the exchange of personal email addresses or planning a facilitated in-person meeting. And then according to that plan that we've established on both sides, we release the identifying information that is consented to by both the donor family and the transplant recipient. So just a snapshot of a bit of stats. So like from year to year, roughly between 40 and just over 50% of donor families and transplant recipients engage in that anonymous correspondence. And to date, BC Transplant has supported around 12 donor family and transplant recipient pairs to connect directly. And there are about 23 donor families or transplant recipients who have expressed that initial interest in direct contact in writing to BC Transplant, but there isn't the corresponding request from their counterpart. And so they would be waiting for the request to come in from the other side.
Thanks. So I think it's a couple of slides from me now. And again, thanks for having us. And I think what's really nice about the presentation today from my perspective is that it really reflects the group work that went on in conducting this research and the importance of the collaboration between lots of different folks, and most importantly, having input from our patient partners. So just echoing that again. So I'm just going to kind of do a couple of slides here from a kind of a background and ethics standpoint. So why are we doing this research? So in a pediatric setting, things are obviously a bit more complex than they are in an adult setting. We know that children and adolescents can't make complex decisions on their own, and that they need support in making these types of healthcare decisions. We also know that there's not a magic age in which people instantly develop capacity to make a decision, and that capacity develops over time. And ability to make a decision is really influenced by your context and your experience and your history. So with children and adolescents, we know that they develop capacity, particularly in those adolescent, teenage, and early adulthood years. And the big question we had when looking at this research is, it's all very well talking about direct contact in the adult setting when you can have two consenting adults who can really choose for themselves what they want to do. But what do we do in the pediatric setting where that capacity might not be there? Do we have substitute decision makers decide for the children and adolescents as we do in other areas of healthcare? And why might this be the right thing to do, or why might it be problematic? We can all see that this is a very personal decision. And, as Jordy illustrated in some of those numbers about, the uptake, this isn't for everyone. And so how do we figure out, okay, who is this going to be helpful for, and who might want this and who might not? So for that reason, we really wanted to look to the pediatric population and the adolescent population to try and understand these ethical considerations in more detail. So when we're thinking about adolescents and children in terms of the risks of direct contact, we know about there's a potential for elevated vulnerability. This is a younger group. This might be a group who is less able to have control over their own situation, their lives, and more influenced by outside factors like social media, friendships, etc. We know that also there could be a big impact of family dynamics. Most adolescents still live in the family home, and so are often influenced strongly by what parents or other guardians in their life may want. And so how do we make sure we are really getting a true voice of an adolescence? And there's also various legal considerations in terms of age of majority, etc. However, we also recognize there's lots of benefits of potential having this direct contact, some of which are those things that Jordy articulated in the adult context. But we want to make sure that we empower choice and we respect choice. And that we avoid paternalism. And I think particularly when we think about the adolescent period, which is such an important period for developing personhood in terms of wanting to allow people to flex that muscle of capacity and understand how to make decisions and well thought through decisions. We really need to take this very seriously. In terms of the next slide, there is some very limited literature on this. So obviously we wanted to take a look before we delved into this research project about what else is out there. And it's very, very limited. When it is discussed, it's really as a kind of a side note. And it's not really been empirically studied, and actually we haven't actually talked to adolescents and talked to families about what they might want. The only time it's kind of really kind of come out a little bit more is in the media, and there was a Washington WSJ journal regarding this in the late 20-teens, which looked at transplant and highlighted this organization, transplantfamilies.org, who advocate for the contact and talked about concerns of isolation and protectionism. So our goal was really to look at the ethical landscape for direct contact for children and adolescents to determine if a program should be extended from the adults also into this group. And to do that, we felt like it was really important to hear directly from those who are affected. So we shouldn't make decisions for folks who are affected by these decisions without hearing from those. That real kind of context of nothing about us without us really guided our research, and partly, meant that we were very, very keen to include patients and families like Shelby, even in the design and conduct of the research. And that was so helpful in terms of making sure we got the questions right when we're thinking about the methods, etc. So I'll hand over to Jordan now. Thanks.
Yeah, so just to continue from here, why is there even the desire for contact? We see that this is existent in the adult space, especially through what BC Transplant has been doing with the direct contact program already. But why are people even worried about this? Isn't anonymous correspondence enough? Well, through our literature search, we found several references for both the donor families and the recipients themselves. Now, as Alice was just saying, there's nothing that's been studied for the adolescents yet, so this will all be from the adult context. But for donor families, often they feel uninvolved or unsupported following a donation. And since the donation is such a huge decision, since it is such a huge part of their life, this is a tumultuous time to feel unsupported. And this can be especially difficult if they feel some sort of bond between them and the recipient. Now, for the recipients themselves, they also experience psychological and physical distress through the process. And we're not just talking about the actual recovery from receiving an organ, we're also thinking about the conflicting guilt versus gratitude. I'm the one who, quote unquote, survived. Why am I the one who got to keep my life while the other person had to pass away? But at the same time, being very grateful for having a donor family willing to give this gift so that I can be the one to survive. That's the kind of sentiments that are found in the literature for recipients. There's also the topic comes up quite a bit about the oddities of incorporation. And by that, it's meant bringing someone else into you, not just the physical organ that gets transplanted in, but taking on some sort of almost quasi-spiritual, mostly emotional or psychological aspect of the other person. And not necessarily knowing who that person is means that that oddity doesn't get resolved. Now, despite this, organizations across the world, both for the adult context as well as definitely for the adolescent context, have felt a burden to enforce anonymity due to the perceived risks of harm, especially when there is a perceived imbalance. Now, from the ethical theories and literature, there's a clear imbalance in the relationship between a recipient and a donor. Namely, there's the gift that can't be repaid. So when this exists, how can one ever alleviate this relationship, this this imbalanced relationship? And because of that, these organizations are saying, no, we're going to keep it anonymous if we allow it at all. Next slide, please. Oh, sorry, I was looking at my wrong screen. So our study questions that we formed with Shelby, as well as Ranjit Dhaliwal, who is from the other side of the patient family group. We wanted to make sure we had representation from both sides. So we had our study questions formed with their help, as well as our methods, which we'll get Shelby to present shortly. we wanted to make sure that from the direct input of both the recipients and the families themselves, that we could look at what the harms and benefits of allowing or preventing a direct contact program would look like for the pediatric population. So we didn't just want to look at opinion or look at perceptions. We wanted to see what do the people who are going to be most involved, the recipients and the donor families themselves, what do they see are the harms and the benefits of this program, either being created or prevented. That way we're not keeping it to the bias of what we might have learned in our medical school or our other allied health profession training. We're actually hearing it from the people themselves. Our next question was, is it appropriate to have parents act as a substitute decision maker for consent to these direct contact programs? And if it is this going to affect whether or not donor families want to participate? Again, this is getting back to what Alice was talking about how kids and adolescents are slowly learning their capacity. They're slowly exercising that muscle. So is this one of those situations where maybe they already have enough capacity to consent for themselves? Is this an area where we need to be extra cautious and therefore they need to have a higher demonstration? That's something we wanted to elicit from this study. We also wanted to know whether or not restricting direct contact to only adult programs was an issue of fairness. We have it for the adults. Why would we want to restrict it from the adolescents and children? Is there a good reason, or is this a justice issue? And finally, what supports need to be in place for those who want to participate in direct contact if we decide that through this study, through policy work, through anything else that needs to happen, that we do actually want to create this program? If that's the fact that of what it results, do we need social workers? Do we need financial or other community supports? What is it that the families, both recipient and donor side, say that they need? With that, we're going to flip it to the methods, and I'll invite Shelby back.
Great. Thanks, Jordan. So with regards to recruitment and data collection, we had potential participants where they're identified through internal patient records at BC Children's and BC Transplant. And we had Jordy and Tom were identifying those individuals. We also had participants who were recruited into 3 broad categories. Recipients who they were a child, they've now gone into the adult program. Recipients as a child who are still a child, their families, and then family members of deceased organ donors. And there were 2 phases for this study. We had the first phase, donor families and current adult recipients, and donor families and current pediatric recipients. So with the recruitment, what we were trying to do is just really send out the broadest possible and gather the broadest possible understanding of our study questions. So that's kind of where we went with that. And, it kind of goes back to, you can go next slide, please. It kind of goes back to what Alice mentioned, nothing about us without us. And what was great is that this entire study had patient partners and, recipients and donor family members as a part of it from the very beginning when they were even started talking about the research questions. So something that is this sensitive and this important had those being impacted involved in it. So it was just incredible. And so when we're looking at the interview design, we had semi-structured Zoom interviews over the spring and summer of 2021. So, it was COVID time, and it was kind of nice where you could keep it safe. There's a lot of vulnerabilities for something like this, an interview like this. So it was just really kind of reducing harm, whether it's COVID or whether it was just in person. It was just a nice kind of safe way to do it. And we also had naive and collaborative perspectives taken to kind of encourage participant-led knowledge. So what that kind of means is we didn't want to cue or direct the knowledge that we were getting or asking from those we were interviewing. We didn't want to have questions that kind of would put them in a direction in terms of what response we wanted to get from them. So to do that, again, we had the patient and the recipients and donor family members in to put together the questions in that it's called naive and collaborative way, so that we could get their ideas coming forward and we could get a response to those questions we asked, because they have got the PhD in the lived experience, not necessarily the ones who are doing all of the research and the policy making. And so again, that's another really good thing to see in research design. Open-ended, room for discussion, that sort of thing. So we also used a combination of, there's a combo of deductive and inductive codes for the analysis. And what that means is basically there was, the deductive codes, there was you kind of start with sort of a predefined set of codes. And that was in our interview guide that we made with the patient partners. And we made that kind of guide with a predefined sort of set of ideas and codes to start a broad range of data collection, so that we can organize it. But we also we went with inductive codes, which is where the information we gathered, we could put together themes and concepts that we were able to interpret from the information they gave us. And again, we really tried to create the interview design in such a way that it was led by the people that we were interviewing, rather than the actual researchers, if that kind of makes sense. So next slide, there we go. So context development, we were just trying to, what does it mean to be a recipient or donor? What's the journey been like for you? What are the emotions that you felt when you were going through something like this? Try to kind of pull out the details and the opinions, but in a way that was very open-ended again, and not defining things for them, in a way that had just kind of getting details and just finding out more about it. And then of course, trying to figure out what were the needs of, what were the needs? What did we need to meet in this kind of environment to facilitate this? Because again, there's a big gap. There's no policy in this. So we have to, figure out the rules, make the rules, and who's better to make the rules than the people who are being impacted by it. So it was incredible how informed this project was by the people, again, who have lived experience. So next slide, please. And finally, I'll just, the sample characteristics that we ended up with all the participants. There's 29 participants over about 20 in-depth interview sessions, 18 women and girls, 11 men and boys. And there were 7 potential participants lost to contact, and 15 potential participants declined. So, some of those were emails that we'd sent out, and they kind of thought they had received those emails as a mistake, like, oh, what is this? No, I don't know what that is. So they didn't really answer, thinking you got spam or something to that effect. So we did lose a few of those. Pediatric recipients who have aged into the adult program, and pediatric were 13. And then we had 11 pediatric recipients currently in the pediatric program, and family members of deceased organ donors. There were 5. So we did have, less interviews and more participants, but that's kind of why. And next slide. So overall, we had 3 adult, 6 adolescent kidney recipients. we had 4 adult and 2 heart recipients, and we had 3 adult and 6 adolescent liver recipients. Next slide, please. So we had a really good representation, and then just in terms of how we went about gathering information like this, in this kind of scale, with this kind of sensitivity, I loved how we did it. I really did. So I'm going to pass it over now to Jordan and let him guide you through the results and discussion.
Yeah. Oh, now I have to cough the moment I come off mute. I apologize. So for the majority of this section of the slides, when we're talking about the different themes that we pulled out, I'm going to be letting the participants' own words speak for themselves. You'll notice that there are names here, and that's taboo in research. These are pseudonyms. So while we were interviewing each of the participants, we asked them if they wanted to create their own false name, their own false identity, so that they still had some ownership over the statements that they made during their interview while still being kept anonymous and private as per the standards of research. We wanted to make sure that for this kind of a topic, it wasn't just participant number 92XY, it was actually a person. So that's why you'll see names here. They are still anonymized and pseudonyms. So for the first theme, this was about the context development. Virtually all participants who could remember, as well as the parents of those who could not, reported that the process of becoming a transplant family, either recipient or donor side, was marked by an increased sense of responsibility, worry, and protectionist thinking. All reported, however, that becoming a transplant recipient or family engendered an overwhelming sense of gratitude. Of the 5 donor families themselves who participated, all expressed that becoming a donor family was meaningful to them and their loved ones. Participants were frequently using words like silver lining to describe the ability to donate their loved one's organs, and all expressed that donation was unquestionably aligned with their loved one's values. Now, all families, both recipient and donor, expressed experiencing very difficult emotions throughout their journey in one way or another. Frequently used words and phrases included things like impacted me for the rest of my life. That's a lot of words, but it came up multiple times, so I included it here. Other words included, it was a roller coaster, or draining, or cried a lot in shock. Several individuals from both groups also stated that the feelings and emotions associated with becoming a transplant or donor family were just entirely inexpressible. There was no way that they could answer my question other than it's inexpressible. Next slide, please. So then we started asking about direct contact itself. This gave us our sense of wondering. 19 participants explained that they wondered about their donor, their donor's family, or their loved one's organ recipient, while 7 expressed never wondering, and 3 did not answer this phrasing of the research question. Of those who wondered, 16 were recipients, while 3 were donor families. Common questions included how old the person was, what their health was like prior to the transplant or to the donation, and what the individual did for fun. People were very interested in finding out what their recipient or what their donor family's loved one just did as a person. Most frequently, though, the main question was whether the other individual knew how much the donation was appreciated from the recipients or their families, and whether the other individual's life had improved from the donor families. 15 expressed wanting a program like direct contact to exist for themselves, while 4 said that they wanted the program to exist as an option, even if they themselves wouldn't choose it. And 6 expressed no interest in a program whatsoever. 11 of the recipient participants, this was pretty interesting, had said that they either met their donor family, 5 of them, or had learned significant personal identifying information, another 6. Those families expressed dissatisfaction with the medical system's current limitations. They explained that they understood why most clinicians were looking out for their safety, but these families also explained that this was something they felt they had to do. Among those who learned information but didn't meet their donor family, 5 received the information through accidental direct disclosure by a hospital staff member, while 1 received the information through actively contacting transplant societies. Next slide, please. So then we wanted to answer our question about the harms and benefits. Beginning with the harms, only 5 participants expressed that they thought contact might result in some personal discomfort or more significant harm. 4 expressed that they were unsure or too far removed to be certain, and 13 others quite explicitly said that they saw no potential for harm. Now, the harms referenced by the participants included being emotionally overwhelmed, having different backgrounds or core beliefs, and therefore being at odds with the person they're now connected with, or that the other family's trauma might bleed into and affect their own traumas. However, surprisingly, despite only being asked about potential harms for themselves, 14 participants expressed that they were more worried about potentially harming the other recipient family or donor family, whoever they're connected to, through their own desire to meet. Regarding the benefits, 23 participants indicated they believe direct contact would have helped their recovery and grieving process, including all 4 donor families who chose to answer this question. The benefits referenced included being able to get closure, being able to contextualize their own experience, and just knowing that their loved one's gift was well received. Again, despite only being asked about the benefits to themselves, 20 participants, including all 4 donor families who responded to this question, expressed beliefs that this could be more beneficial for the family that they are connected to. Several expressed that while they might personally benefit, the main reason they wanted direct contact was so that others could have benefits, so that they could provide some benefit to the donor family if they were the recipient, or vice versa. Next slide, please. This one doesn't have any good quotes. It's policy. There's not really much that's quotable from policy, so you get a little bit of a break from quotes. Questions regarding the policies elicited 2 main tensions among participants. The first being whether it would be appropriate for a parent to consent to direct contact for the child or adolescent, and the second being at what age a youth could make the decision for themselves. Among parents of recipients, there was no clear consensus about whether parents should consent, adolescent recipients should consent, whether they should even decide who is more appropriate or if it should just be case by case. Among recipients, half felt that they should have the sole ability, while the remaining half thought that it should be a family decision. So this was really mixed. This was really up in the air, and it requires more research to be able to fully capture from the policy side. From a donor family perspective, only 3 participants answered. And given our already low numbers, we didn't want to draw any conclusions from this, as we were afraid that we wouldn't be accurately representing the views of this population. Now, regarding the appropriate age for being able to consent, parents and recipients were distinctly split. The responses from parents tended to claim that their child would have been able, or currently would be able, as long as they were a teenager. Of those who gave explicit numbers, they ranged from 14 to 16. That was pretty common. Recipients, however, both the graduated recipients who are currently adults, followed by the adult program, but were transplanted as kids, as well as current kids themselves, they felt it should be much younger. Those who gave explicit numbers ranged from 9 to 12. Now, importantly, on both counts, graduated recipients and current adolescents appeared to share the same views on consent, which means we're able as researchers to effectively combine those numbers as they seem representative. It seems like this is a desire or a belief that is consistent as their life stages change from adolescent to adult. Next slide, please. So finally, the 3 most commonly requested supports were psychologists and counselors before the meeting, social workers before and after the meeting, and mediators during the meeting of direct contact. Other supports included family meetings, mentorship from those who had already gone through the program, information packets, financial aid, and clinician involvement during the meeting itself. Additionally, recipient families felt strongly that any support they receive should also be given to the donor families. Again, this connects back to what the literature is showing about donor families feeling unsupported. And it seems that just the people in the community themselves already implicitly recognize this. They were saying that they want this to apply also to donor families without any provocation, without any seeding of the idea. Again, because we were doing this from a naive standpoint. Almost all participants who responded to the questions that we had in this section indicated that families should be told about the possibility for direct contact in the general information packets before transplant, as part of information discussions immediately after transplant, as well as shortly after during a follow-up. Because there's so much information that's shared during the transplant process itself, they wanted multiple opportunities to internalize the information, internalize the message that this was an option. Regarding the interval of time to wait for meeting, responses ranged from immediately, they've just transplanted this organ, please let me meet the family, to 1 year later with no clear front runner. Accompanying this, however, was the frequent clarification, it depends on individual recovery. And finally, participants were asked what they wished more people knew about being involved in organ donation or transplant. And while this doesn't have a direct correlation to the study that we were doing, we wanted to make sure that the voices of recipients, their families, and donor families were able to guide future research projects. So many thoughts emerged from this question, including some common items like remembering that transplant recipients are just like any other person, that transplants are not cures, and that there needs to be more public education on this, that being a donor can give your family a sense of peace or purpose after you yourself pass. But the big one was that transplant research has been, and this is a quote, negligent to include lived experiences of both the recipients and the donors. So there was the idea that researchers in general have failed to create enough pediatric focused studies, as well as enough lived experience focused studies. So that was kind of helping guide where things should go next. Next slide, please. One more, I guess. So what does all this mean? The study findings highlight the distinct desire among pediatric transplant community, at least in British Columbia, for a direct contact program. This appears to exist for both recipients, their families, and donor families. Now, while pre-study discussions with clinicians indicated a belief that the harms outweighed the benefits, participants themselves indicated the opposite might be true. Most participants from all three groups expressed more benefits than harms, and many only discussed harms in reference to whether their own desire might harm the person that they're connected with. The main benefit that recipients assumed donors would experience was closure, and this ended up matching the most common self-reported perceived benefit from the donors themselves. And the main benefit that donor families assumed of recipients, it was a little harder to pin down. They thought that there would be a general miscellaneous benefit. And interestingly enough, that actually matches the most commonly given perceived benefit. Over half of the recipients said that there would just be a miscellaneous benefit that they couldn't put into words. So it seems like both groups are really in tune with what each other are looking out for. Next slide, please. Now, both recipients and donors know more, or at least seem to know more than clinicians and researchers think they do. And this was one of the biggest messages that was a take home from this project. And this is knowing more about their own health, their situation, about who each other even are. And they can expressively recognize that much of the research in transplantation is primarily focused on physical health, rather than spending equal attention to their mental, social, spiritual, psychological health. And this is kind of something that we've taken to say the transplant community, both recipients and donors, care about their overall best interests. And we've been doing, as researchers, a pretty bad, like as a research community, have been doing a pretty bad job because we only seem to be focusing on the medical best interests. And Javi Carroll, who is a philosopher of illness, explains this in ways that researchers in the group might understand. And it's the difference between the insider and outsider perspectives. So insider perspectives are necessarily first personal and can sometimes be second personal if you're the caregiver of someone. But outsider perspectives, the ones that clinicians take in most situations, are necessarily fundamentally third personal. So we only can understand as much as our experience gives us, is essentially what this says. And being third personal to donation, we don't actually know as much as we think we do. Next slide, please. So the development of a pediatric direct contact program is justified based on the identified and expressed desire within the transplant community. Importantly, these pediatric programs need to be consent-driven. And from our research, as well as the interviews that we've done, this needs to be consent-driven on the consent of the pediatric recipient and not the parent or guardian. The clear difference in attitude surrounding consent, paired with the fact that recipients necessarily must be involved for direct contact, indicates that these adolescents ought to be the central decision maker. Parents and guardians can and indeed should be involved. We don't want to suggest removing them, but this is not an emergency medical situation. This is not even a medical situation. So it should be focusing on the adolescents themselves and allowing that exercise of the capacity muscle. And now, while this might seem like it pushes consent too far, there's several models in Canada that allow adolescents to consent for their own treatment or their own services. So in BC, where the study is based, the Infant Act outlines that adolescents under 19 can provide their own consent if they demonstrate capacity and the decision is deemed in their best interests. In Ontario, where I'm based, with the Healthcare Consent Act, anyone who can demonstrate capacity with no reference to age is able to consent to their own services. The crucial aspect in most Canadian provinces and territories actually is the adolescent's capacity as outlined by the Canadian Pediatric Society's position paper on medical decision-making. So if capacity is present, then the adolescent can and indeed should be the one driving this situation, this discussion. Final slide, please. Now, some might still think that this isn't enough, that this isn't justifiable yet. It's all kind of nice and fancy, but it's not quite there. So we also looked at the fact that this program could be developed from a harm reduction perspective, given how many participants have already met their donor families or have located significant identifying information. Harm reduction approaches sometimes are difficult to get buy-in from risk-averse stakeholders because it seems like we're recommending advocating for these harms. But instead, this takes potentially risky behaviors. Whoever defines risk it's not part of the harm reduction kind of definition. It's just anything labeled as risk. So potentially risky behaviors can be incurred, but we reduce the potential harms by allowing this perceived risk to occur in a controlled setting rather than in isolation and without support. So what this would mean for a pediatric transplant is allowing information exchange in a controlled, mediated environment rather than through random chance or through online databases. And this could also just better integrate resources and supports such as the family counseling or mentorship that our participants said that they wanted as part of this process. Again, remember that many of our participants said that they wanted to have this meeting and that they would welcome help from the hospital, from the government, but waiting for formal help wasn't a barrier. They were going to do this anyway. So having this from a harm reduction lens, and this is the last thing I'll say, also helps us follow a more flexible support system structure. And with that, we can turn it over.
Hi, thank you so much. Obviously, you guys may have noticed that Alice Virani had to step away. She had an urgent meeting, but thank you to the four of you guys for a fascinating presentation as always. I want to open the floor up to questions or even comments. There is one in there already. Have you made all donor families and recipients of these rules so that they at least know how to make the request to meet? This is in reference to the program that was set up for the adults.
Yeah. So we have done as best as we can to kind of broadcast the availability of these programs widely. For anyone, all the information about anonymous correspondence and direct contact is available on the BC Transplant website, of course. And for anyone who takes the step to start anonymous correspondence, every time I send correspondence, forward correspondence to either a recipient or a donor family, the information about the whole program, including direct contact, is always included. So if you are someone who is interested in or engages in anonymous correspondence, you will definitely receive the information of direct contact. And yeah, so try to make it as widely known as possible. And yeah, our method of doing that really is just making direct contact the logical next step or extension of what the anonymous correspondence program is.
Thanks, Jordy. And just to clarify, of course, this is only in BC. Every province is different. So we are
Of
talking
course, yes.
specifically about a program in BC. I know it's very different in some other places. Please feel free to pop on, just unmute yourself and jump in if you have a question, or put it in the chat. Nicholas Murphy has his hand up.
Hi, thanks for that fascinating talk, and congratulations on the study. You guys are obviously doing some pioneering work here. I'm wondering if in your research, you came across approaches from other jurisdictions where direct contact has been facilitated for decades, like Israel and some places in the US. Do they have any experience at the pediatric level, or is that confined to the adult level, or is there just nothing out there on that? Thanks.
Yeah, so I can take this one. We did run across that during our literature search, during kind of trying to formulate what is the context that we're operating in. But again, for the most part, it is just the adults. We haven't been able to see anything from the pediatric side. When they are mentioned, there's one that kind of immediately comes to mind, and it's a legislation or a bill or whatever they classify them as in Australia. And that did the best job at talking about pediatrics, but it was only like one page of a 50, 60 page document. And it didn't really give much information. It just, I say it did the best because it at least recognized instead of just being a throwaway paragraph.
That's great. So it really is pioneering work you're doing. Thanks.
And on that note, like, it was really difficult to find or get a sense of like how any of these programs are operationalizing this. And it definitely didn't seem like there is kind of like the programs that are coming at this work in like a systematic way, or at least publishing their policy or practice in this area.
And I think what's important too is you know, having something that's groundbreaking and new. It's so important to listen to patients so that their needs are being met and defined by them and not by others. And that's what this project really did a great job of.
Thank you, Shelby. I do recognize that it is just after 1 o'clock, but I think our 3 remaining panelists are available to stay for a few more minutes because I do want to get all the questions that we might have. And I think we could discuss this for a long, long time. But if you do have to go, thank you so much for joining us. If you do have additional questions or comments afterwards and you didn't have time to stay, then you can contact Manuel and he can get those questions forwarded to the panelists. So Leonard, I see you have your hand up, so please feel free to jump on.
Yes, hi, thanks. This is really interesting. Can I ask you, does your research apply specifically to deceased pediatric donors or deceased donation in general? Or would this apply to like a living adult donor to a pediatric recipient?
We only looked at it in the context of deceased donors. I think that's more of a question for Jordy with the direct contact as it currently exists for adults, though.
Yeah, for like, of course, this is very specific to BC. Our legislation in BC is a bit more like open-ended or permissive, and so we were able to go down this route of direct contact without requiring like a major legislative change. I know in some other provinces in Canada, to be able to adopt similar programs would require a legislation change. And that being said, this was initiated in BC Transplant specific to deceased donation. However, the living donor programs in BC are working on adapting the policy and process from the deceased side into the living side for adult direct contact. And so logically, essentially, we're currently have a working group with the multi-organ transplant clinic at BC Children's and BC Transplant to figure out how we're going to operationalize this program in terms of policy and a practice framework, which again could therefore be adapted into living donation as well.
Thanks very much for that.
Leonard, I just want to add one thing, though, that I think is important to recognize is that because we're talking about donors and recipients within BC, that is what BC Transplant has control over. So a lot of the pediatric living donations, in particular the livers, are not done in BC. So that would not, now you're talking about cross-jurisdictional, provincial boundaries. So like, for example, our donor family came from the United States. So even with the implementation of this, it's likely that we would never meet through the official program. And then I think that is the one issue with a lot of pediatric transplants, is that a lot of the donors and the recipients are not within the same province as they are for adult donation and transplant.
You're totally right, Elaine. Thanks for raising that.
Thanks, yeah, very much. And as an adult donor to a child recipient,
thank you.
I can imagine that raises a lot of other complexities too, of course.
Yes, yes.
Absolutely. And I mean, broadly, like when we zoom out on this, my hope is that the work that we're able to do in BC is only going to help move the conversation forward across the country, and that by doing this work in BC, we'll then be able to, that'll lead into the discussion about how do we do this interprovincially, that will lead into the discussion of how do we go about bringing about legislative change in other provinces so that we can adopt this work across the country. And hopefully the framework that we are beginning, we're a couple years into creating in BC, can help be kind of a map for how to do this in other provinces as well.
All right, thank you. Does anyone else have any additional questions or points of discussion that they want to bring up?
Sure, I can quickly jump in. Really got a couple of comments here. I really loved your last slide where it said that the program can be built kind of through a harm reduction lens. I think that's quite innovative. I've never really approached direct contact through that lens and through that framework, or at least have thought of it through that. Is that something? I guess where did that notion come from? What is it that made you guys say, hey, a harm reduction lens? Is that something that came in the literature? Is that through the focus groups, et cetera? Where did that come from?
That comes from ethicists. So both myself and Alice being really good at finding loopholes. We're kind of like the good lawyer. So instead of trying to find a loophole to shut something down, we're trying to find a loophole to open something up. And one of the things that we had a lot of discussions happen from our pre-study meetings with clinicians, our meetings with clinicians during the study itself, was just this constant concern about the harms without any focus on the benefits. So from hearing that constantly come up, Alice and I just kind of thought, you know what? Harm reduction. Can we make this a harm reduction thing? And then we did a little digging and presented it to the rest of the research group. And we thought all kind of heads came together and thought it was a good idea. So, you know what? If you don't care about everything else that we've just shown you, at least care harm reduction.
Mm-hmm. Mm-hmm. No, brilliant. The other quick comment I wanted to make is interesting going through, reading your presentation, and one of the pieces that really stuck out is when the parent perspective of what is capable for consent for an adult, or for a child. And I think you guys said 14 and 16. So I received my transplant at 21, so past, into adulthood. But reflecting on my pediatric experience going through the system, I thought to myself throughout this presentation, like, no, it should be earlier. Like, I could have done that earlier. So when you brought up that, I think it was as young as 9, I'm like, brilliant. Yeah, that would have been me. Like that was my perspective on that. So I just wanted to throw those 2 comments in there.
And it was kind of funny because there's one interview that sticks in my mind. It's just so explicitly around that particular question. And it was a mother and her son who were interviewing together. Son was like 11, I think. And she was like, yeah, I think he'd be ready when he's 14. And he just whipped to her and said, I'm ready now, thank you.
So good, so good.
That's funny. I can actually add to that. First the harm reduction, having the patient family partners involved, we can actually anticipate increased almost anticipate potential harms and address them even a little bit more so. And then, it's Manuel, like yourself, I had my first transplant at 14, pediatric context as well. And I've mentored a lot of people through that stage as well. And it's just interesting when you have other people kind of deciding on things for us, with us, compared to, our own thoughts and definitions. It's really interesting to see the difference. So, I think it was just really interesting how it all kind of came together.
Donna, I just saw your comment, and I think that's so appreciated. And I certainly encounter that as I'm facilitating correspondence between donor families and transplant recipients, where so much of my conversations with recipients and donor families in anticipation of writing is how I'm so focused on the well-being of the person on the other side, and how do I not add to their add to distress, add stress to this experience, but how do I actually communicate in a way that reduces stress or reduces harm? And so we're walking into this from a place that it came up in our study too. We're walking into this in the context that each side is already so concerned with the well-being of the other side, even more so than they're concerned with their own well-being. And so it just makes me think that we're starting from a position where everyone involved is already set up for success in a way. And when we think about this from a harm reduction perspective, like in the status quo, people aren't even able to have a conversation around harm or around expectations or around hopes or around fears, right? And so moving forward with this in a framework that is supported by the healthcare system, it allows for us to even ask the question of, if this happens for you, what are you scared of? What are you hopeful for? And maybe those conversations help us. Maybe those conversations lead someone to a place where they're like, actually, I thought I wanted this, but I don't now. Or maybe it allows people the space to think about being creative and thinking about, oh, what could this add to my life? How do I want this to fit into my life? How do I not want it to fit into my life? It's just, if we don't have a policy, if we're not willing to say yes, then we can't even have a conversation, which I think is doing everyone a disservice.
I think it's interesting because it's almost like this barrier that we've set up as a protection can be harmful in some instances. So as to being overprotective, which is what you alluded to in your presentation. But also, again, I'm an adult that had a transplant. My perspective was, wanting to know that the organ donation process did not complicate their grief and their healing and their grieving process. So it's, and again, these are all things that we don't think of, because the emotions around transplant, which there was a researcher from Australia presented all the different relationships and emotions and the web. We don't have the language or haven't thought about them or conceptualized them yet until we go to use them. And then it's like we're spinning, trying to come up with the right word or emotion. So I think this is an excellent study. I really love it. But it's allowed so much more.
Thank you so much, Donna.
Yeah, I think, Donna, it's so true. Like you're pointing out, where, you know, if you don't assume the risks and harms and have us as the patients and recipients and donors involved in assessing what those risks and harms are, it can be overall, you know, less paternalistic and more realistic and beneficial to all of us, just like you were saying. So, and Jordy as well.
Joanna, you had your hand up. So before we say goodbye, do you want to jump on?
So I'm the other pediatric parent on the call. So I've always been kind of on the fence about whether this is a good idea or a bad idea. And I really like to see that there's a program put in place that has a social worker involved to make sure that these things happen properly. That's really awesome. My concern comes to the consent piece with the kids. It was mentioned, you know, I'm in Ontario, so there is no age of consent. And I probably have a bias for the consent piece. For my non-transplant child, he needs to consent to treatment, and because he won't consent to treatment, the harm is actually happening to our family. So if my child is put in the position that they can consent to meeting the donor family, and they decide that, but maybe I'm not necessarily for that, and then something goes wrong in that meeting, and hopefully it doesn't, but if something went wrong, I'm the one that has to pick up the pieces afterwards. So then the harm is then done to our family. And that's just something, I don't know if that was considered or not, but that's something that jumps out at me because I am dealing with that whole consent piece and within my family. So I see it a bit differently.
I think, thank you so much for sharing, Joanna. And I think that like, it just speaks to the complexity, the enormous complexity when we're thinking about consent in the pediatric context, as opposed to the adult world, where it's just two adults, usually two adults, who are making an informed decision about themselves. I think that, like, as we're just embarking on this work to figure out how do we actually put this into practice, and it's so crucial that we have the support framework built around a family and a pediatric recipient as we're entering into, or as we're just even talking about this question, to be able to make a plan for either moving forward or not moving forward in an individual basis that takes account for the needs of everyone that is impacted. And whether that looks for, like, whether that means that, you know, in certain cases consent might come from a parent, but assent needs to come from a youth, or whether that means that consent needs to come from a youth and assent needs to come from a parent. Regardless of that, we need to be able to make this work in a way that works for both or all involved, and that everyone involved feels supported and doesn't feel like they're walking into this like with their head just barely above water.
Thank you, Jordy. The one thing, though, I just want to add is that at the end of the day, when you're talking about putting this program into place, no one's forcing anyone to do anything. So ultimately, it's still up to the individual to say yes or no. So I feel like sometimes, like you guys talked about this, it's like everyone puts up all these roadblocks, but wait a second, you haven't even asked me or my daughter, what would you like? Or the recipient or other recipients or donor families. At the end of the day, everyone still gets the right to say yes or no. It's like, and even Jordy, you said that comment, if we say yes to like having this kind of program, but you shouldn't be saying yes. We should be the ones saying yes or no, right? And that speaks to that whole thing about how, hey, we know a lot more than the medical system gives us credit for. And I think especially around pediatrics, like I hope I wasn't one of those parents who said that my daughter needs to be 14 or 16 to consent, because hell yeah, she absolutely can speak her mind now and has been able to. I think these kids, and I know Joanna has the same experience, they're a lot older than we give them credit for. And they're not like your typical 9-year-old child. They've gone through a lot already. So I think, again, like so much there to unpack. And I think it should be kind of like the way we want to frame organ donation. Everyone should be asked. And if you don't ask, you're taking away that opportunity already. You've already made the decision. Oh, well, they for sure don't want to be organ donor. They don't want their loved one to be an organ donor. But you're not giving them that opportunity. And I feel the same way about this. It's not like everyone has to do it. It's not for everybody. I totally get that. And then the only other thing I want to say is that because our donor family was in Nevada at the time, and of course it's the Nevada and Northern California Donor Network is the one that coordinates. Exactly, Donna. Thank you. The answer is always going to be no, because if that's your default, no one can say yes. And so that network obviously has dealt with a lot of these types of meetings before. And so they worked with our donor family and with us. And I had asked the coordinator, I said, like, does it ever go bad? Like, if two bad things ever happen? And she said, honestly, in all of the meetings and the correspondence and those kinds of things that she had coordinated, it had never, imploded the way that we like to sort of like, catastrophize. I mean, obviously things aren't always the way you think they're going to be. Like I would say in my case, like, I feel like there have been some learning moments, like, for me, because you don't know the background of the person who is the one who's given your loved one the gift. But when she said that, she said, it's never been a situation where, like you hear all these things about what if they ask for money or like those kinds of things. It's never happened. So that's not to say that's scientific at all, but I think anecdotally.
No, I mean, the thing is, the anecdotes in this situation matter so much. And like Shelby was saying, like throughout this whole presentation, like it has to come from people with lived experience, like it has to. And the thing that I kind of said before in responding to Donna is that like without like a permissive policy in place, like we can't even ask the question. Like we can't even start. We can't even ask, is this something that you would want? Is this something you would not want? Oh, it is something you would want. What does that mean for your life? Like we can't even go down this road to really hear from people, whether pediatric or parent or adult. Like we can't even have a sophisticated discussion where it's as it stands right now, right? And so yeah, just the crucial thing is that we respect people as experts in their own lives, I think, and that we're able to actually just have sophisticated discussions about this, and that we don't force people to go and do their own sleuthing and like maybe jump into a situation that they weren't prepared for, or that they even if it goes well, that they wished they would have had support to do.
Exactly. And I think it's like you're saying, we know more than you think we do. And honestly, we would just like to have the support available to us if we wish to kind of go forward through this process. Even just knowing that it's there, it's available, would be fantastic, because it's happening anyways. We know a lot more. So, social media and everything. So I love what this study did and how it went about it and how you guys did it. So Great job.
Thank you all. Like I said, I think we could just keep going, especially
Yeah,
the
really
group
good.
that we've got.
You have a whole other hour, guys. You want to go for it?
Thank you. And thanks to Jordy and Shelby, of course, Jordan and Alice, who had to leave early. And thank you to those of you who have hung on till the end. Of course, this is just a series in the CDTRP's webinars. And next week, CDTRP will be hosting Dr. Dawn Richards and patient partner Linda Hunter, who will be presenting on the co-creation of patient engagement in research training models. Go check out the CDTRP website to register. Thank you so much. I'm sure that this will be an ongoing topic of discussion for quite some time.
Yeah,
Have a great
excited.
day.
See you guys.
Bye, everyone.